Hi, friends. Welcome to another episode of our podcast, Living Well. I am recording this podcast from Manipal. Manipal actually derives its name from Mannu and Palu, if I'm not mistaken, which is mud and lake, right? Or a hill. So it's a beautiful place, nestled away about an hour away from the nearest airport, which is Mangalore. And I'm in a fantastic institution, which was the first private medical college established in our country. But what makes this more interesting is our guest today. We have with us Dr. Naveen Salins. He's Professor Naveen Salins, and he heads the Department of Palliative Medicine here. In addition, he is the Associate Dean of this organization. So he juggles he wears many hats, and he's with us here to talk about living well. And I wish we could have a grand welcome for him, like a round of applause. And probably I'll put it in the edits if that's the case. Welcome, Dr. Naveen.
Thank you, Mahesh, for this opportunity.
Yes, so as you see here, he's a man of few words, but very crisp and precise. I will just take a deep dive in the next 15 to 20 minutes or maybe half an hour of conversation with him. The first part is he's had a long week. I believe he has been flying for more hours than he's been on land, because he was recently in Toronto, if I'm not mistaken. Can you tell us a little about what you were doing in Toronto?
Okay, so in Toronto, I was attending the meeting for the Lancet Commission on Human Crisis of Cancer. And one of the subcommittee of the Lancet Commission is palliative care, where we envisage developing palliative care solutions to mitigate the human crisis of cancer. So I chair the subcommittee of palliative care as the commissioner of the Lancet Commission.
So, sorry to interrupt you there, but you are the chair of the Lancet, this subcommittee. And so, what was the global representation there? How many of them were from India? Or the only one from India?
So I'm the only one from India, and
that's huge.
Yeah. So, and I'm chairing the palliative care subcommittee. We are mainly focusing on the low resource countries. When I say low resource, it's low income and low middle income countries, and the crisis of cancer that exists there, and how palliative care could offer some solutions to mitigate the crisis of cancer.
That's brilliant. So this Lancet Commission is essentially a global body, and we have someone from India who's in a leadership role in this organization also. That's a huge moment for India, and we're all very proud to have been associated with you in some shape or form in our career. So Dr. Naveen, before I go on and ask you more about the Lancet Commission, I want you to just describe your medical background for those who have, those of us who are listening to this podcast. So we would just like to know how your journey brought you into the world of palliative medicine.
So I'm a physician by training.
That means an MD. You did
MD in
medicine.
general medicine. Yeah. So after I did MD in general medicine, I worked in acute medicine. So a lot of my work involved working in ICUs and emergencies.
And was that in India?
It was in India. It was in fact in Manipal.
Oh, okay.
During that time, after finishing my training and working as a consultant in general medicine, a lot of times I used to see patients with probably terminal illness or patients with advanced illnesses, and most of them were managed in ICUs, and they were getting discharged against medical advices, and also probably they were receiving care that was not appropriate for them. And this always intrigued me in terms of, is this the only way, and were there any other ways to do? And that pursuit of finding another way probably led on to doing palliative care.
So this is a very beautiful line that you used, that you were intrigued by the way in which people were being cared for in critical care units, correct?
Yes.
Do you have any experiences that you would like to share with our listeners? Was it a specific incident that provoked it, or was it cumulative?
I think cumulative, but also probably some of those personal experiences my own grandmother, who was 94 years of age, was treated in an acute setting, and basically she had a flash pulmonary edema secondary to a diastolic heart failure. And actually, I read first about palliative care in a cardiology textbook.
Well, that's so interesting because that's really interesting because a lot of times we talk about palliative care from just the oncology perspective.
Yeah.
So here you're talking about cardiology. You went through the cardiology textbook because of your grandmother.
So it was usually for me to find out whether anything else could have been done, and that anything else could have been done led to palliative care. And
wow.
Yeah.
So yeah, for some of our listeners may not be from the medical background. So what we essentially mean to say is if the heart doesn't relax as much as it should and it doesn't function as well as it should, what happens is that the blood pressure pulls back and it goes into towards the lungs, and there can be fluid filling up in the lungs, and that can be a sudden process leading to a lot of complications. And critical care, that's acute care, manages these people who suffer with these conditions. Now, you were in critical care, and then in India, in Manipal, and then where did you move from here? Did your palliative pursuit start here?
Yeah, so I used to look for these training opportunities, and there was
like
none.
Most of us, as
there was none. There were some short courses and
correct,
very basic courses, but there was no formal training.
That's right.
So I, from consultant, became a resident again.
So your disease, your disease-related journey, that the pursuit of your this excellence, it started off as at the level of a consultant. You went back to being
to become a resident for next 4 years.
And where was this?
This was in Australia, Adelaide. So they would not let me straight away into palliative medicine. So I had to do one more extra year of general medicine there, where I worked as a resident in general medicine.
What's that experience like? Because a lot of people who leave the country to pursue medical education abroad, they have to again do that, work as a registrar resident.
Yes.
So I remember working as a fellow after being a consultant. And how was it for you?
It was okay, maybe because I didn't work too many years as a consultant. So a lot of things I had to unlearn and adapt to a new circumstances. But that was again a thrilling experience to do. And I learned a lot of things.
I'm sure.
And where we focus here mostly on knowledge and the depth of knowledge and the rarity of knowledge. There the focus is on more pragmatic approach and practical skills and doing the common things really well, rather than focusing on the more rarer things.
Absolutely. So there is a saying in medicine that when you hear hoofbeats, you think of horses, not zebras.
Yes.
So that's amazing. So you worked there for 4 years, and that led to your becoming a consultant in Adelaide.
Yes.
And what made you move back to India?
I always wanted to come back after I finished,
So
and I briefly worked as consultant because I wanted the flavor of being a consultant there, not just being in training.
Yes.
Yeah. So after I moved back, I worked at several places in several positions.
That's right.
Yeah.
So you've, if I'll just recapitulate, you were in Bangalore with an organization, a private organization. Then you moved to an one of the apex educational institutions in Mumbai, then India actually, the Tata Memorial, which is a huge cancer center. Everyone knows about it. And of course, our paths crossed in Mumbai, where I was fortunate to meet you, and we got to learn a lot from your presence in Mumbai. And then you moved to home. So it's like a long, much needed homecoming of sorts.
Yes.
So what made you move back home?
So I always wanted to work in a non-cancer setting, because I started in a non-cancer setting. I didn't start in a cancer hospital.
So it moved full circle. From acute care, you went all the way to Australia, then came back to different places, and you come back home.
Yeah. And see, each one has its own charm. When I was working in Bangalore, it was in a cancer hospital.
That's right.
And gave me an opportunity to set up something in a corporate private cancer center. And when I moved to Tata Memorial, gave me an opportunity to be part of a first specialist palliative care education program in India, which is an opportunity for me. And then when I moved back to Manipal, it was an opportunity to set up something in a non-cancer setting and also in a critical care setting, which was my passion from the beginning.
From the beginning. So the prodigal son, I would say the prodigal grandson returns to back home. So I'll just get into the main part of our discussion that I was thinking of asking you, that your organization, like it's the first private organization in medicine in the country, 1953, and today about 70 years later, today almost 71 years later, today we find that your organization is leading in terms of caring for these people who are in critical care units, who have much complicated needs. Can you tell us a little more about how you have integrated caring for these very sick and dying patients in critical care units? What is it that your organization has done? What are the things that you have done over the last few years?
Okay. So, as you rightly said, our organization has evolved over 70 years.
That's right.
So, starting from a very small clinical establishment now to almost close to 2,500 bedded hospital with 200 ICU beds.
Wow.
Yeah. So it's a big with all possible specialty, both at subspecialist and specialist level. So this need is there. So you're treating. It's a tertiary referral hospital where the referral comes from 3 states: Kerala, Karnataka and Goa.
So the north of Kerala would be
north of Kerala, south of Goa, and almost 8 to 10 districts of Karnataka. So the local population who access care are much smaller. They may just constitute 10 to 15%, whereas 75 to 80% comes from the other. So most of the patients that we get are already treated outside. They are all complex cases.
So they come in for specialty opinions.
Very specialty and very complex. So whoever comes to ICUs in Manipal are really sick patients, and they've been given some form of acute care outside. And for us, the most important thing for the hospital is to manage that load. And one thing, if you ask me upfront, what we have done in ICUs is, for any ICUs to be successful, is what they call it as ALOS, the average length of stay. And that determines the turnaround time in the ICUs.
Yeah, because it's a very precious resource.
Yes.
It's a life-saving resource.
Yeah.
Yeah, so you need to...
Yeah, so the one thing that we have achieved after integrating in ICU over 3 to 4 years is to bring down the ALOS from 15.9 days to 8.1 days.
That's almost a 50% reduction.
So that means that those patients who need not be in the ICUs or should not be in the ICUs are out of ICUs. And those who need ICU beds are getting
into the ICU, correct.
This is the huge relief to the administration. And that is probably one of the strongest motivation for them to support palliative care, because they are able to see the outcomes of integration.
So there's better survival because more people get an opportunity to get life-saving resources.
Yeah.
And people who need more comfort care, who don't need to be in the ICU, are better managed.
Yes.
So it's like saying having a much better medical management system.
That's
right. How much of this is medical and how much of this is administrative?
So for anything of this magnitude to happen, you need to set processes in place.
Okay.
And all those processes have to be agreed upon processes mutually by all the stakeholders. So when I mean stakeholders, it's not that I lay down the process and others abide by this.
It's not like a diktat, like I'm going to come in.
So it has to be co-designed or co-created initiative. So we started an initiative called Blue Maple Project. Which was a co-designed project where we had stakeholders from critical care, emergency medicine, all medical specialties and subspecialties, surgical specialties. They all became it's a co-designed project where we decided how are we going to manage these patients, what would be the level of consensus that we are going to have, what is the processes from beginning to end. So we wrote it up as a process, we implemented it as a process, and I can say that through this implementation of this process, we have brought out close to 2,000 patients out of ICUs.
That's a huge number, and both in terms of the numbers of people around, and the impact you're making on 2,000 lives, 2,000 families actually.
Yes. Either in the form of withholding or withdrawing life-sustaining treatment. And this was very useful even in COVID times, where we were able to triage patients in terms of who would benefit in terms of ICU resources. We had created a COVID care plan, and we have published those our results also.
So one of the challenges that we face when we talk in medicine is the fear of addressing patients with the science of how to deal with people who are really sick and dying, and respecting their choices, respecting their wishes, and giving them the best care. Now you have this personal experience with your grandfather. So if you look at it from that point of view, are there any instances where, because the Blue Maple exercise that was done here, where it brought all brilliant minds together and you designed a scientific plan which has really impacted people and helped them, and I believe, if I'm not mistaken, that is one of the references that the Supreme Court has also, one of the references that they have used in designing what has been the current verdict on the care of dying patients or the end of life care plan in India, is it not?
That's right.
Wow. So my question here is, the challenge that we face with people, do you have any anecdotes or any experiences in terms of people who've been positively impacted by these actions?
So majority of the time what we do, always we try to achieve consensus in everything. So when I say consensus at many levels, so one consensus that we achieve is at the care provider level, at healthcare provider level. That means all of them who are part of this, we all agree upon that this is probably inappropriate to continue care or futile to continue care.
So I will just pause you there and ask you, when a doctor says it's inappropriate or a doctor says it's futile, what does it mean to a layperson?
So when we say that any care that what we provide should be in the best interest of the patient, and when we say best interest, that means that it will create a benefit which outweighs the harm that it could have.
Correct.
So suppose if continuing an intensive care therapy is going to benefit, we look at two kinds of benefit. One is the what we call quantitative benefit. That means how much it would impact the length of life of the patient. And when we say length of life, we look at short-term length of life and long-term length of life. The second thing is what is called as a qualitative benefit, in terms of quality of life, how it's going to impact. So in any ICU measures or any intervention that we do should have both benefit in terms of length, both short and long term, and quality of life. So if everyone agrees that this aspect is going to be compromised. So for example, we have a patient with heart failure. Let's give an example of heart failure. Continuing intensive care measure might increase the length of life by a few days or few weeks, but definitely not longer. But the life that is there would be spent more times in the ICUs with a tube down the throat, with many lines, where person may not be able to communicate and probably would have more health suffering. Not just to the patient but also to the families, and not just at the level of physical suffering but at many levels, emotional, financial and other things.
When they want to spend time with their loved ones.
So we make a very conscious decision as, are we acting in the best interest of the patient? If we are not acting in the best interest of the patient, then whatever care that what we are providing is not appropriate, isn't it? So the first thing that we determine is appropriateness of care.
Yes, how useful is it for
How
that?
useful it is. That is the first level of consensus that we. The second level of consensus that we achieve is in terms of talking to the families, where we really speak to them and tell them that this is the experts, that what we think is the most appropriate line of management. However, we are not going to take a unilateral decision. It's a very shared decision making space.
You're respecting their choices. Yeah.
So you come with your expectations, your beliefs, your value system, and we come with our medical expertise. And let's see how we can align and match together. And at the end of the day, you are neither satisfying me or them. We have to satisfy the patient. Yeah, who is not going to participate in the decision.
That's the best interests of the patient.
And most of the time, in my experience, what I can say is, none of the families want their loved ones to suffer needlessly.
I understand.
So if your communication is clear, honest, and you are telling upfront, and your intentions are noble,
Transparent and
noble, I don't think anybody would have a doubt in those things. 99% of the time we have been very successful. There are always exceptions to the rule, but so it's how effective is your communication at that point of time.
So I think as the saying goes, that the biggest myth in communication is that it has already taken place.
Yes.
So many families may not have. It's a privilege to have doctors like you and your team you are talking, discussing with families, discussing with patients. So many times they feel there's no news coming in. The person is inside the ICU for days on end, and they may feel that they are probably suffering. That's not what they wanted. And so you spoke about two levels of consensus. The first one is the best medical plan in the best interest of the patient, and the second was having consensus with the family. What happens after this?
So once there is a consensus, and when the medical team and the family agrees that let's not either withhold an escalation of a treatment or de-escalate a treatment, then there is a consenting process where there is a clear consent form that what we have, and then we also explain to them what happens when we do not escalate or when we de-escalate, what to expect and what is the nature of the care that we are going to provide, and how the family would be supported during that process, how the patient would be supported through that process. So there is a clear explanation to all of that.
So there's a full ready plan. It's not just talking about, this is not what we are doing. In fact, there's a list of it.
Yeah.
It seems more like a life-facing event where you're looking at the quality of life, the pain management, and all the other elements that define good medical care.
Yes.
There. Yeah. So when you, and as we said that you're the pioneers in this, and how has good end of life care, or as I would like to call it, care of dying patients, because death is inevitable. All of us know it. We talk about it, but somewhere in the medical world, we seem to have a lot of reservations. As you were pioneers in this, what were the challenges that you have faced?
So there were probably challenges. More than the challenges, it's the fears.
Fears.
Yeah. So fears in terms of, is it ethical, is it legal, is it moral? 3 levels of. I think morally everybody feels this is the right thing to do.
Who says, okay, let my relative suffer?
Yes,
Nobody will say that.
So morally, I think there is no question in there.
Agreed.
The biggest fear is legal.
Correct.
What does the law says about it? And my constant question is that I have shown them even before the Supreme Court judgment. I always used to make a joke. You bring me a piece of paper from the law which says that every patient has to be resuscitated, I will change my practices. Because every law, even in the Indian Penal Code laws, every law, it says that in the best interest. Do everything in the best interest. And I always used to tell my ICU physician, if doing resuscitation and continuing ventilation is in the best interest, and you are convinced beyond reasonable doubt that is, then you please follow that. But if you think otherwise, then the law will not prevent you, because law wants you to do in the best interest of the patient.
Yeah, for the citizens. So
Yeah,
the law is
yeah.
meant to safeguard the
Safeguard.
citizens from
So if none of the law will allow you to cause more suffering, then there is already there, isn't
You're already
it?
supported.
Yeah. So the even if you, so second part is the ethical part, and ethics is very clear: beneficence versus non-maleficence. And you make the family empowered to exercise their autonomy, and at an organizational level you're exercising justice so that the
All
most
four.
precious resources are used. So there is, again, from an ethical angle also, you are doing the right thing.
Correct. So one of the challenges you faced were fears.
Yeah.
Now, in terms of the benefits that if say we integrate good end of life care and good care of advanced illnesses and dying patients in a hospital, what are the benefits? You mentioned one tangible, like an objective benefit, which was ALOS. What else comes to your mind?
So the second thing also, any patient, even if I'm talking from the pure economic sense,
That's an organizational sense.
at an organization economic sense, for them, continuing to treat a patient who is in an advanced illness in an ICU setting is not economically viable. Okay, that's another thing. The third thing is the huge goodwill that it would create. That means that you have been honest, you have told what is the right thing.
Correct.
You have not continued an inappropriate treatment, but you had the ability to communicate and be honest about it, and take families into confidence. The goodwill that would generate. The amount of goodwill that it has generated here is huge. As we are constructing our hospices, many of the families who have had end of life care, they have come forward years later and told, we heard that you are developing our family, we want to contribute because this is the care that we have received.
Amazing.
Yeah.
So and that brings me to the point of the hospice.
Yeah.
So you're coming up with and all best wishes in this endeavor, and it's amazing to see the effort that you're putting into designing a hospice where people, and a respite care center where people with advanced diseases can be managed.
Yeah. And it's not cancer specific. It's
not
for
cancer,
all illnesses.
Lovely.
All illnesses, all age groups.
And you've had families of people who have been treated before.
Yes.
They have come up
and they are actually who are telling us that we heard about this. Definitely, we want to. So it is coming from them.
So it's like a social movement. So what you're doing here at an organizational level, it's helping.
Yeah.
It's helping it. And how does it help the caregivers? Like in medicine, there is always this talk about physician burnout because you're always in high stress situations. How does it help physicians if you practice good end of life care practices in your critical care units and your wards? How does it help doctors? And nurses, of course, doctors, nurses.
So most of the time, the lot of this burnout is not just the physical exhaustion of the work. It is the being always forced to do something that's against your beliefs. And lot of time, if you ask ICU physicians and neurologists, I don't think that this is the right thing. But we have to continue to do this one.
Yeah, they feel that this treatment may not be appropriate, but we have to continue.
So a lot of time they felt unburdened that this decision has been made.
Correct.
And they are able to implement or execute a decision that is coherent with or aligns with their belief system.
And in the best interest of the patient.
And in the best interest of the patient. And that itself could be unburdening for them.
No, we've experienced this. In fact, when we discuss good end of life care practices, this is one area in medicine where families come back and they send messages. They send that, okay, this is we've lost our loved one, but their last days were very comfortable. They were very peaceful. They did not have suffering. So in India, normally we think about suffering and quality of life Are there any metrics? Is there any research that is being done here to address the quality of life and suffering element that happens in palliative care?
Yeah. So there are researches which are being done on health-related suffering. In fact, there are some questionnaires that was also developed, which is contextual to India regarding health-related suffering. But most of them are restricted to cancer. Most of them have been developed in cancer setting, and I personally believe that what's developed in cancer is not directly transferable in a non-cancer setting, because the illness trajectories or the course of the illnesses are very different. Although there may not be a direct research that is being done, what we do probably is a very informal way of evaluation through the family perceptions, and most of the time the common theme that comes out is that we never knew that this was also possible. And other thing that is, if we had ever known this was possible, we would not have gone through this way.
Correct.
So this is what the family, very strong family perceptions.
So the families have some sort of regret if they
yeah.
So can you just describe the department and how it is structured over here?
Yeah. So right now we are 5 consultants.
Okay.
So we have a formal training program, that's MD in palliative medicine, and we have 2 residents joining each year. So we have 6 residents and 5 consultants. We have, apart from that, nurses also in the department. And although all of us do all the work, some have taken areas of interest. Like my area of interest is in ICU palliative care. We have another consultant who does more pediatric, another consultant who does more renal supportive care. So that we also, one of the things that I always tell my team is that what should be the USP of this department is that we do original research, and although a lot of evidence from palliative medicine is from the West, but most of them may not be contextually relevant. So we create evidences in each of the work that we do, because only once we create, that is the credibility of our work. So
That's right.
So Dr. Kritika is doing an ICMR funded project on embedded model of pediatric palliative care.
Wow.
Dr. Anuja is doing a lot of work on advanced care planning in renal supportive care. I am doing some work on ICU palliative care, and each one of us should, after this research, should publish those things, and that's how it goes out to the world, isn't it? And this is what comes out from India.
So that's it's extremely inspiring, because it's the original model that when Dame Cicely Saunders started the hospice movement, and she was talking about not just providing care but also providing research in that field. So it's very inspiring to hear these experiences. Now, if someone's listening in and they are thinking about taking up palliative medicine, what would your advice be to, say, someone who's given their exams entrance and they want to take up palliative medicine as a career? What would you tell them?
I feel that it's a very bright choice, not just because I'm running a program. There are the amount of patients with advanced illnesses, the magnitude or the burden of patients with chronic and advanced is huge, and it is unfortunately chronically ill patients are treated with the acute care model.
Correct.
And acute care model is to diagnose and treat, doesn't fit in for patients with chronic illnesses or advanced illnesses, both cancer and non-cancer. So palliative care is founded on the principles of chronic care, not just chronic care, but also founded on the principles of coordinated care, where they are able to receive care at all settings, at all phases of their illnesses, and not restricted to some form of illnesses, And I always believe that fragmented medicine should become unfragmented through palliative care. Now we have specialists for everything, right hand and left hand also. And another important aspect of palliative care is to rehumanize the dehumanized medicine.
That's a beautiful line. I think I'll probably use it somewhere.
Yeah, that's a very important aspect, and that's a moral responsibility for all the healthcare providers. Is how do you rehumanize the dehumanized care that is there?
So you're like filling all the gaps in care, all the gaps between binding everyone a binder, and amazing.
And if you are able to really practice palliative care in the true spirit, I'm sure that you'll be the most busiest person, and there'll be always work.
So very inspiring words for anyone who's looking at taking this up as a career. Now just coming back to the original question about you being jet lagged and you sparing so much time after a long flight. So what is your vision now that you're a chair of the Lancet Commission? What is the roadmap forward? How will this benefit LMICs, that's low and middle income countries? What are the benefits that you foresee?
So what we have done in Lancet Commission, I'll slightly explain to that, is we did three parts to that. The first part is we examined the evidence. Examine the evidence in two parts. What are the gaps and how these gaps have led to the crisis in most of the countries, and what were the solutions in terms of where all palliative care is developed and what impact it has created. So we looked at two parts, and we have done a framework synthesis, a method of systematic review, where we compared those indicators using the WHO framework for palliative care development and another framework called as an integrated palliative care framework. So we have identified a lot of gaps which has led to the crisis. At the same time, places where palliative care is developed, how it has impacted it. The second part, what we did was, we did what is called as a theory of change exercise, where we identified what should be the impact of palliative care development and work backward in terms of looking at what are the long-term outcomes needed to achieve the impact, what are the intervention that we should have, what are the preconditions that must exist. And later on, it led to developing certain statements in terms of what are the solutions or the recommendations for palliative care. So it's primarily aimed at multiple levels, at an country level for the policymakers, at an organizational level for an institute, and at a very individual level, what we could do. So this is some kind of a roadmap that we have developed through this commission.
Amazing. So you've analyzed the problem, you've brainstormed and arrived at some sort of, used the scientific method to arrive at possible solutions, and provided that framework to different organizations. And I hope that they are all implemented to the best possible extent, and we hope to see that change in the ground level. And one of the last questions, and I'll leave you, as I said again, we know you're jet lagged, you've had a long flight, and thanks for taking this time out. And just for anyone who's listening, we are doing this podcast when the whole department is done and dusted and everyone's gone home except for this gentleman who I'm talking to. So the last question I want to ask is, what does the word living well mean to you?
Okay. So we always think of, when we say living well, most of the time it is been, we use a very reductionist approach and tell quality of life, So I always have a much larger construct for living well beyond quality of life. The quality of life may be one of the ways to objectively measure. But when we say living well, if I am in the last moment of my life, and if I have an opportunity to reflect back, and if I see that level of fulfillment and say that yes, I have lived this life well, when we say living this life well, that means it need not be reduced to lack of pain or lack of suffering. It must be probably much beyond that, in terms of that, okay, this is what I expected and this is how I lived up to that expectation. And lot of time that opportunity is denied because of over medicalization, because we want to everything to have a very reductionist approach, and we define living well as lack of pain or lack of suffering or improvement in scale of quality of life. So this
So
is
numbers.
probably my thought process.
Correct. It's more comprehensive.
Yes,
and
much more comprehensive. Yeah.
It's an amazing discussion, and I've used the word amazing very aptly, I believe, because thank you for all the insights, and thank you for impacting so many lives, and not just in the way that you work and in your actions, but also in how you are quietly working towards consistently teaching, empowering, and educating people, and impacting a lot of care providers also, and trainees, and future generations of palliative medicine providers. And thank you for this podcast recording. And we wish you all the best. We wish you all the best with the hospice. We wish you all the best with all your endeavors in this organization. Thank you.
Thank you so much.